Greetings, everyone. Welcome to the 202nd session of the online Optom Learning Series, or OOLS. And for today's session, we have with us Dr. Micaela Gobeille. Dr. Gobeille received her optometry doctorate and the Masters of Science in Vision Science degree from the New England College of Optometry. She has then completed a residency in primary eye care, vision therapy, as well as low vision rehabilitation. Currently, she is an assistant professor in the Department of Specialty Advanced Care and Vision Science at the New England College of Optometry. She's also an attending optometrist where she sees patients at the NECO Center for Eye Care, the Boston Medical Center. With all that experience, her research focuses are on evaluating low vision patients' outcome, and she has been publishing a lot on this subject matter of low vision and vision impairment. With all that, she's also lectured intensively nationally as well as internationally for topics pertaining on low vision and doing grand rounds as well for low vision patients' cases. So welcome, Dr. Gobeille. Thank you so much for joining us on this Sunday morning for this session. And let me just leave the screen time to you.
Great. Thank you so much for that introduction. So today I am going to be making the case for contrast, evaluating vision beyond 6/6 or 20/20. And we're going to start off our discussion today by jumping into kind of a motivating case. So we have a 92-year-old female who has a history of a branch retinal artery occlusion in the right eye and primary open-angle glaucoma in both eyes. She notes that things look like water and she's having an increasing amount of difficulty seeing. She depends on good lighting at all times and really struggles if she can't get the light positioned correctly. When reading, she notes that she is an avid book reader and has a much easier time when she's able to do this using a Kindle or a Nook or some other tablet-type device. She notes that she's unable to read the newspaper and that paper books are much more difficult. For mobility, she's having trouble with curbs and steps, noting that they kind of all blend together and are difficult to see. She tried using a cane but kept tripping over it, and her son had to mark the steps at home and reposition the rugs to make things more visible. She does live with her son, who helps with the cooking, cleaning, and laundry. She had previously stopped driving a number of years ago and gets rides from others. She has no glare complaints, but in terms of her hobby of weaving on a loom, she notes that this is also becoming increasingly difficult and that she has to make sure that the lighting is positioned correctly in order to see well. Our patient comes in with hand motion vision in the right eye, in 20/30 or 6/9 in the left vision and binocularly. Her pupils are equal, round, and reactive to light, and she has an afferent pupillary defect in the right eye. Her motilities or eye movements are smooth, accurate, full, and extensive, and confrontation visual fields reveal an inferior nasal step in the right eye and full confrontation, so full visual fields in the left eye. Based on these presenting tests, we might suspect that this patient would be doing pretty well. She has good acuities, her visual fields are fairly well preserved. Overall, one would anticipate good visual function. However, our patient came in with a number of other complaints. So when we evaluated her contrast sensitivity using the Mars contrast sensitivity tests pictured here, she measured 1.0 log CS, which is a severe impairment. So here we see a patient with clear functional difficulties that include reading, mobility, and her hobby of weaving cloth on a loom. However, she has good visual acuity. So from this case, we can see that contrast sensitivity is able to impact function. And throughout the rest of this talk, we'll discuss different methods that we can use to evaluate contrast sensitivity in the clinic. And we'll also discuss how contrast sensitivity can influence low vision patient management. So we measure vision in the clinic all the time. The most common way that we do this is with visual acuity testing. Here, we're doing a maximum contrast test with black letters on a white background. This is to test fine detail central vision, and it's really a test of spatial frequency. Spatial frequency evaluates how often sinusoidal components repeat. And we think of this more often in vision science, where we might show sine wave gratings. And we can see that these oscillate between black and white, and it's measured in terms of cycles per degree. So one black and white oscillation is one cycle. And in this grading seen here, we can see 2 cycles per degree. If we look at that grading compared to the letter above it, we can see that there's also bars of black and white oscillating in letters. So we can see that that letter E is a good example of how spatial frequency is really a measure of visual acuity. They're kind of one and the same. We can think about spatial frequency as being high or low, where in low spatial frequency, we have fewer bars per degree. So we have a larger letter, whereas in high spatial frequency, we have more bars per degree, so we have a smaller letter. So spatial frequency maps pretty well to letter acuity, which we measure in clinic all the time. However, contrast sensitivity is a bit of a different character. Contrast sensitivity is defined as a function of the difference of the luminance in the object compared with its background. So we can see in this black E on a gray background, the contrast is the difference between the black color of the E and the gray color of the background. We can define contrast a couple of different ways. The first is Weber contrast, which is the difference in maximum and minimum contrast divided by the maximum. And this is the definition preferentially used for letter stimuli. So we commonly use this definition in some of our clinical tests that we'll talk about in a moment. We can also talk about contrast in terms of Michelson contrast, which is the difference in maximum and minimum luminance divided by the sum of maximum and minimum luminance. And this option is more often used for sine wave gratings. The contrast threshold is defined as the contrast that's required to see a target reliably, and we usually report this in log units. And contrast sensitivity is just the inverse of the contrast threshold, and this is what we'll more typically talk about in our clinical practice. Contrast sensitivity can be affected in a range of ocular conditions, including cataract, corneal disease, macular degeneration, glaucoma, and really most ocular diseases come with impaired contrast sensitivity. So this is a really prevalent problem to have. We can evaluate contrast sensitivity a number of different ways. First, we can plot out the full contrast sensitivity function. Here, we're plotting contrast sensitivity as a function of spatial frequency on a log scale. So we're showing targets of different spatial frequencies in different contrasts and plotting a curve that characterizes how they do based on different spatial frequencies and different contrasts. This curve has a few different characteristic points on it, and it has a specific high spatial frequency cutoff, which is shown by the triangle here. This corresponds to 100% contrast, and in turn relates to our visual acuity. So for someone with normal vision, with 20/20 or 6/6 vision, this would occur at 30 cycles per degree. We also have a peak to the contrast sensitivity function. This typically occurs at around 3 cycles per degree, which translates into about 2200 or 6/60 vision. So the best contrast sensitivity that we have occurs not with small letters, not with very large letters, but with something in the middle. We also have a low frequency roll-off, whereas spatial frequency decreases as the optotype gets larger or we have fewer bar oscillations in a grading, we see poorer performance in contrast sensitivity. So bigger letters we have poorer contrast sensitivity to a certain extent past that 2200 point. The shape of this contrast sensitivity curve can change in characteristic ways. We know that the peak of this curve, that red dot, will be shifted to larger sizes or smaller spatial frequencies in normal aging with low luminance and in ocular disease. We'll also see a decline in the contrast sensitivity function for older eyes in intermediate and high spatial frequencies. And finally, in ocular disease, we'll see a decline in low, intermediate, and high spatial frequencies. So we can imagine that this contrast sensitivity curve would kind of be shifted down and maybe a little bit to the left in our low vision patients who have underlying ocular disease. While this is a really thorough and comprehensive method to assess contrast sensitivity, it's less often done in the clinic. Assessing the contrast sensitivity function can be time-consuming since we have to show patients different contrasts at different spatial frequencies, and there's many different presentations that need to occur. And it can also require specific computer software. We have the fortune that as many clinicians start using electronic charts where we can vary the contrast and the letter size, we're sometimes able to do this using existing methods that we may already have, but it depends on the software that's available. The method more commonly used to evaluate contrast sensitivity in low vision clinical practice is by using optotype charts. Here, we're measuring contrast with large optotypes. The idea is that we want to characterize where that contrast sensitivity peak is located, so we use large letters of differing contrasts to determine how far patients can go. One test that we use is the Pelley-Robson. This test is done at a 1 meter test distance such that letters subtend 2.8 degree visual angle. We have triplets of letters here. So when patients read this chart, each triplet is worth 0.15 log CS. However, the first triplet is not worth anything. So if our patient were reading this chart and they got the first triplet right, they would have a contrast of 0. If they also got the second triplet, they would have a contrast of 0.15. And if they then got the third triplet, they would have a contrast of 0.3 log CS. So we can use this to measure the contrast sensitivity, the peak contrast sensitivity. We also will use the Mars contrast sensitivity chart. This test is done at a 50 centimeter test distance, and letters here subtend a 2 degree visual angle. In this test, each letter is worth 0.04 log CS. So if our patient got the first letter, that would be worth 0.04. Our first letter counts for something with this test. If they get the second letter and the third letter, that would come up to a contrast sensitivity of 0.12 log CS. Both the Pelley-Robson and the Mars contrast sensitivity tests have been shown to have good agreement in their measures. So either of these tests can be used in clinical practice. One of the benefits of using these optotype tests is that it allows us to monitor for progression. We have normative data available from these tests that allows us to compare to someone with perfectly normal vision based on age. So if you have a patient who measured 0.96 contrast sensitivity, we can see from this chart over here that with that 0.96 contrast sensitivity, that counts as red, which corresponds to a severe contrast sensitivity deficit. So we can compare how reduced contrast is. We can also use this test to monitor for progression. If we think about a patient with 0.96 contrast, if a year ago they had 1.44 contrast sensitivity, that would suggest that their contrast sensitivity has worsened, which might suggest changes in their ocular health condition that are worth evaluating. So contrast sensitivity can be compared over time and to a normative patient population here. Unfortunately, not all of us have these wonderful optotype tests available in our clinic, so some people need to be a little bit more creative with their testing. One option to screen for a contrast sensitivity deficit is by evaluating near acuity using both high and low contrast sensitivity. Here, a two-line difference suggests a significant contrast sensitivity loss. Although we can't categorize if it's mild, moderate, or severe, the presence of a two-line difference does suggest that it's an important one. So if a patient read down to this line on the high contrast chart and performed two lines worse on the low contrast chart, we would suspect this patient of having a contrast sensitivity deficit and want to modify our rehabilitation plan accordingly. There are also contrast sensitivity tests that we can use when working with special populations. These can be used in people who are nonverbal, whether we have children or adults with disabilities. This can evaluate patients who can't give us a verbal response to still give us some measurement of their contrast sensitivity. So on the upper right portion of our screen over here, we can see the Meyer-Cran double happy test. We also have the Ohio contrast cards pictured down here, and then the Hiding Heidi cards pictured down here. So these are preferential looking tests where the patient is shown a card, and then they will automatically look at whichever side of the card has the visible target on it to them. So as the contrast gets more washed out and we reach their limit, they will stop reliably looking at the double happy face or the sine wave grading, and they'll start being less reliable, at which point we can determine that we have assessed their contrast sensitivity threshold. Spot checks can be another contrast sensitivity test to use in individuals who might not know their letters or who might be able to provide more responses than just the preferential looking test and want to be more engaged in our testing. So here we have patients go through this piece of paper that has these gray dots on it, and they X out the dots as they go. And then there's a scoring sheet that we use to calculate the contrast sensitivity based on how far they could go with assessing these gray dots. Finally, some electronic tests have a contrast sensitivity function. So a number of acuity charts, we can actually also assess contrast sensitivity on them by modifying the contrast of the letter stimuli that the patient's looking at. And contrast sensitivity is so important to assess because it provides really important information. This is helpful for patient education as well as for clinical decision-making during our low vision exam. So what has the literature told us about how contrast sensitivity impacts function? Well, first, contrast has been implicated in fall risk. Here's a study looking at patients with macular degeneration and their self-reported falls or non-falls injuries, such as a laceration or collision. This study found that contrast sensitivity was associated with both increased rate of falls and with other injuries. So contrast sensitivity can contribute to mobility concerns. Another collection of studies, I should say, looked at driving. The impact of cataracts on mobility study, which was done in Alabama in the United States, was a prospective cohort study which enrolled a large number of subjects to evaluate older adults' cataract risk associated with state-reported at-fault crash. So when we're talking about driving research, it's important to think about the outcome measure, which in this case is state-reported at-fault crash. So they're really evaluating, did patients get into a car accident? And if they did, was it the driver's fault? Was it the patient's fault? So only accidents that are considered the patient's fault are counted here. So in this first study, looking at visual risk factors for crash involvement, they found that contrast sensitivity was independently associated with crash involvement, while visual acuity and glare were not. And they found that drivers involved in a crash were 6 times more likely to have a severe binocular contrast sensitivity deficit. So contrast sensitivity could be an important predictor of crash risk, which is important to consider when giving patients advice on whether they should be driving or not. A follow-up publication from this group found that cataract with intraocular lens insertion reduced risk of further crash involvement by 50%. So for patients with cataract, removing those cataracts can improve their driving. We've talked about contrast and driving mostly in the context of cataract thus far, but what about in patients with other ocular diseases and other conditions? Well, a study looking at driving in patients with visual field loss has found that poor contrast sensitivity correlated with driving performance as well as specific maneuver and skill combinations. So the contrast story of it impacting driving performance holds up even in other ocular conditions when there are other visual functions that are impacted by disease. Contrast sensitivity has also been considered in terms of performance of instrumental activities of daily living. In this study, patients were evaluated performing a battery of different activity of daily living tasks, including dialing a phone, finding items on a shelf, making change, managing medications. In this study, they found that patients infrequently made errors, but they took significantly longer to complete different tasks if they had poorer contrast sensitivity. Contrast sensitivity has also been implicated in reading. We know that in patients with normal vision, reading rate is relatively insensitive to reduced contrast. We know that the rate decreases by less than a factor of 2 for a 10-fold reduction in contrast. So print can be quite washed out before someone with normal vision has difficulty reading it. In comparison, for low vision patients, we find that the critical contrast, or the contrast at which the reading rate halves, is much higher than for low vision patients. Is higher for low vision patients than for normal patients. So patients with low vision have less tolerance to reduced contrast sensitivity than do patients with normal vision. We also know that patients with cloudy media tend to read faster with reversed polarity. So if a patient has cataract or corneal disease or vitreous floaters, sometimes reversing the contrast to have a black background with white letters can improve reading speed. With all this in mind, what chief complaints do we commonly hear from our low vision patients who have contrast problems? Well, these patients often tell us that they need more lighting. They say that they need to bring their reading material to the window on a bright sunny day in order to read, or they have to get right on top of the right light in order to read what they're trying to see. Patients will also report difficulty with lower contrast materials, like food packaging or newspaper print shown here. Rather than having the pure black on white that we see with other options, a newspaper is often more faded, or food packaging might have an alternative background color, which makes it difficult. Patients also will often report difficulty with stairs, curbs, or cracks in sidewalks. And this kind of makes sense because all of these are roughly the same luminance or the same color when we're looking at them. If we're looking at the stairs in the bottom left picture here, we can see that for someone with poor contrast sensitivity, since those stairs are not marked, they would all kind of blend together. However, if we went and painted the edge of each stair yellow, it would stand out a great deal more. Similarly, in that picture in the upper right corner of the screen, we can see that there are cracks in sidewalks, and we can imagine how someone with poor contrast sensitivity might have difficulty in that situation. Patients with impaired contrast sensitivity might also report difficulty with night driving. We talked a moment ago about how contrast sensitivity was related to crash risk in drivers, but here at night driving, it's even more difficult because patients now no longer have the bright sunlight that they would benefit from during the day, making it all the more difficult to detect details in the road. Patients may also report difficulty recognizing faces. If facial details are all approximately the same color, the patient might have more difficulty parsing out the different parts of the face and recognizing a loved one or a friend. So with these many common complaints in mind, let's look back at our patient's complaint that we started out this session with. So our 92-year-old female was telling us that she needs good lighting all the time and that things look like water. She has an easier time when things are presented electronically with bright black print on bright white print, making it maximum contrast and brightness. She has more trouble with low contrast reading materials like newspapers. Her difficulty with curbs and steps makes sense in light of her impaired contrast, and her son marking the steps and positioning rugs to increase visibility sounds like a smart environmental modification to make life easier for our patient. Finally, her note that it was hard to position lighting correctly for weaving cloth on the loom also points to a contrast sensitivity deficit. So for this particular patient, her main complaints all make sense in terms of common complaints that we hear for patients with impaired contrast sensitivity. So what can we do to help these patients? Well, the first thing we can do is to modify the environment in order to make vision easier. This might be done through direct task lighting. We'll want to recommend to these patients that they need good lighting for any condition where they need good vision. So if they're reading, they want to bring the page that they're reading within a couple of inches of the page. They might benefit from customized lighting in their kitchen so that it's right on top of a workstation. So if they're preparing a meal, they can have best vision due to the contrast. We can also recommend high contrast for important tasks. So if a patient is eating rice out of a white bowl, it will be much harder to see that food than if they put that white rice in a black bowl where it has maximum contrast and will stand out better. Similarly, if a patient were preparing a meal and they were cutting up chicken on a white cutting board, that would be much harder to see than if they were cutting up chicken on a black cutting board. So the color kind of blends in, and we can change the color of our cutting board or our plate to maximize contrast to improve visibility. Finally, a yellow tint has been recommended. Studies have shown that a yellow tint can enhance contrast. Not all patients appreciate this or notice its improvement, but it is an option that's worth trying for your patients. Contrast sensitivity may also prompt us to modify our device recommendations. We might recommend a higher amount of magnification than one might expect is needed based on a patient's visual acuity. So we might have an expected amount of magnification needed, but if a patient has a severe contrast deficit, they might need more. Severely impaired contrast sensitivity might also suggest that we use electronic rather than optical magnification, because the electronic magnification can make things brighter and bolder, while optical magnifiers all degrade contrast to some extent. Impaired contrast sensitivity, contrast sensitivity may also suggest binocularity despite very asymmetric vision. So a patient might have very good vision in one eye and very poor vision in the other eye, but they still prefer to function with two eyes together rather than covering one eye because their contrast sensitivity is better binocularly than monocularly. So back to our patient. She has her numerous lighting complaints. She reads best on electronic options, and she's having difficulty positioning the light correctly for her hobby of weaving cloth on a loom. Her contrast sensitivity was severely impaired as assessed with our Mars Optotype contrast sensitivity test. Given her numerous complaints surrounding reading, we evaluated her reading while she wore her habitual bifocals. She demonstrated a slow reading speed and had a little bit of a hand tremor, so the page kept moving because her hands were a little bit shaky. Her reading slowed at 2M sized print, which is about 2 times the size of newspaper print, and she thresholded or was able to read no longer when print was half the size of newspaper print. Next, we introduced a light to see if she was able to get any further when she had good lighting positioned within a couple of inches of the page. Here, she was able to read down to 0.8 M, indicated by that orange box shown here. And for this patient, she noted that it was easier and more comfortable, but she still felt like she was looking through water with her reading. So after noticing that lighting made a good difference, we moved on to evaluate different devices. Since our patient had a hand tremor, we focused on devices that would sit on top of the page so she wouldn't need to keep them stable and supported as much. We started out with a 3x stand magnifier. And with this device, she was able to comfortably read down to small print, achieving that 0.8 M print size again. But she noted that things still looked like water. We thought that perhaps the bulkiness of this device was bothersome to her. So we tried an alternative, a 2.2x Macrolux, which is a device with dome magnifier type optics, but it has a bright light built into it. And with this device, she was able to read down to 0.8 M. She was comfortable, but again, print still looked like water. So finally, we moved on to evaluate an electronic magnification option. Here we evaluated the SmartLux, which is a small portable electronic magnifier. And with this device, she was able to read very small print, but she noted that things no longer looked like water. She needed the maximum contrast. She wanted the white background with the black letters, and she was able to read with very little magnification. She was impressed with this option, and her son was pleased that we found something that allowed her to no longer feel like she was looking through water. So for this patient, we started out by educating her that the water description of her vision that she was experiencing is due to her impaired contrast sensitivity, where things look faded out or washed out. We did update her reading glasses so that she could read with direct task lighting. And we educated her on the importance of that lighting and making sure that the light source is kept as close to the page as possible. We recommended reading on tablets because this could provide more contrast enhancement than reading on paper. The tablet could make things brighter and bolder, and she could also incorporate low-level magnification if she ultimately decided she needed it. Since she enjoyed reading books and the newspaper, we talked about the options for downloading ebooks and also recommended considering a digital newspaper subscription so that she could pull up the newspaper right on her tablet and forego the faded contrast of the paper version. Next, we recommended an in-home assessment with an occupational therapist who could address lighting and glare sources in the patient's environment. Since this patient has this specific goal of weaving cloth on a loom, We felt like this was something that warranted further consideration in the home, since we can't easily bring a loom into clinic for me to evaluate lighting sources with her. So the occupational therapist was able to go out to the patient's home and evaluate what was going on with the lighting and figure out how to position the lighting correctly so the patient had best vision for cloth weaving. We planned to follow up with this patient in 4 to 6 months to revisit the magnifiers that we had discussed at this visit and make sure that the occupational therapist visit had gone well. And at this visit, we also planned to discuss a loop or a telemicroscope for the loom if the patient was still having difficulty at the home. Ultimately, this patient did quite well with her OT home assessment, and when she followed up, she didn't feel that she needed any additional accommodations. Lighting and tablet reading worked quite well for her. So from this patient, we can see that severely impaired contrast sensitivity was identified using the MARS contrast sensitivity test. Electronic magnification was better for this patient than optical magnification because with it, she could make things both brighter and bolder, as well as a little bit bigger. Lighting for this patient was critical. This was true both of reading, where we wanted her to position the light within a couple of inches of the page, and for her hobby of weaving cloth on a loom, where she needed to figure out a way to get that light positioned just right without obstructing her view of her weaving. Incorporating an occupational therapist visit was helpful for this patient to incorporate her lighting accommodation and allowed us to address all visual demands. So in conclusion, contrast sensitivity has an important impact on patients' function, and we can evaluate it during a clinical exam. Reduced contrast sensitivity may motivate different low vision rehabilitation interventions, such as lighting and contrast enhancement. And importantly, to all of us clinicians in the audience today, vision is more than 6'6". While acuity is a very important test, there are other parameters around vision that matter to patients and how they function. And I will now open the floor to any questions. Thank you for your attention.
Thank you so much, Dr. Gobeille, for taking us through this entire case-based plus theoretical presentation of contrast sensitivity. I think this is the test we kind of usually miss out, and something which we can do it for our patients on a routine basis, right? There was one question which came in quite early when you were talking about the different types of contrast sensitivity tests. So somebody wanted to know, what is your take on these new projector charts which has low contrast visual acuity measurements? Would that be beneficial, or any experience on using those onto clinical practice?
Yeah, so those low contrast charts in the electronic charts can be helpful. They're not the mainstay in my clinical practice. I personally prefer the MARS or the Pelley-Robson because it has that normative database available, so I can compare and contrast over time. That is a really nice tool, those electronic charts, for someone who wants to start screening for contrast deficits, but doesn't have the resources to purchase an electronic chart immediately and, wants to start being more thorough about this. We do teach our students how to use it during their clinical lab sessions for the low vision course. So I do think it's a valuable tool and something that can be incorporated immediately without needing to get other equipment.
Right. Yeah. Because I think most of the clinics and optometry service practices, primary eye care practices now, they are all incorporated with these LED screens where you can have the 100% contrast for your normal refraction, but then you can also have an option, as you were mentioning, to alter the contrast. So probably that could be a starting point. And once you have probably you can refer to places who can measure contrast if you find a deficit, but at least if you are doing contrast sensitivity as a test to measure, that would be great, right?
Right.
Okay, the one question which just came in, I'm going to put it up on the screen. Somebody is wanting to know about the cognitive load which is involved in the letter octotype and tumbling E letters. So is probably not related directly to contrast, but if you could throw some light in your experience about the cognitive involvement pertaining to contrast, maybe if I can modify that.
Sure. So typically in a clinical session, we evaluate visual acuity or contrast sensitivity using letters. That's kind of our standard practice. When patients are unable to provide that information, perhaps due to cognitive impairment or communication deficits, we'll often turn to other options like the tumbling E that the question asker mentioned. So the tumbling E is certainly an easier test. We're asking the patient to indicate the direction that the E is pointing rather than naming it. So it's certainly a less cognitively demanding test. But it does allow us to still get a measurement in a patient who otherwise we wouldn't be able to get that test completed.
Right. Yeah. So that's probably there is some influence in short, but again, decision of a clinician is really important.
Mm-hmm.
And what's your take on the assessment of the contrast sensitivity for driving license? Is that a standard practice?
Yeah, I'm so glad someone asked this question. So, driving requirements are different by, in the United States, they differ by state. They certainly differ across countries and globally. Here in the United States, contrast sensitivity is not a required screening test, which is interesting because contrast sensitivity is a pretty strong predictor of crash involvement. Unfortunately, we in the United States, like many of us internationally, not all clinicians do assess contrast sensitivity. Many of us in the low vision community do, but unfortunately, it's not quite as mainstream as we'd like in the primary care setting. So while contrast sensitivity is not used as a screening test for a driver's license, it is a really important test. And when patients come in looking for recommendations about driving, my low vision patients coming in saying, oh, I'm not sure if I can meet the requirement, contrast is certainly something that I take into consideration when I recommend that they continue to drive or restrict their driving or stop driving altogether.
That's right. Yeah. I think color vision has been the mainstream when it comes to driving license across the globe.
Right.
But contrast is kind of left behind, right?
Right.
Okay. And any recommendations of the room illuminations or the surrounding illumination while measuring, the digital contrast test? Is it different from different tests, or is there any standard illumination which you would recommend to have?
Yeah, that's a good question. I think it probably depends on your system, and I would encourage you to look into the instruction manual that probably came with your electronic acuity chart at some point in time. When we have our students do it in the lab, we usually have dim room illumination to cut down on any glare reflecting off of the screen. But of course, the contrast between the letter and the background are calibrated through the screen. So the room illumination is more a factor in terms of glare on the chart than it is in terms of the actual contrast difference between the letters.
Right. Yeah. And is there any difference between the far and the near contrast sensitivity? Is it routinely practiced or measured or something on these lines?
Not typically measured. Usually we're lucky to get one contrast sensitivity measurement from a patient. The Pelley-Robson test is done at 1 meter, which is kind of an intermediate distance. And then the Mars contrast sensitivity is done at 50 centimeters, which is more of a close distance. And we know that those two test results correlate pretty well. But if you're going to evaluate contrast sensitivity on a patient, it's wise to pick one test and stick with it across time so that no variation in the chart influences your measures.
Right. And I think you did mention about the use of yellow filter for enhancement of contrast sensitivity. So is there any particular percentage of the color filter which you would recommend, or anything which is readily available, or is there a trial and error method which you would try? How to come out with that yellow color percentage?
Yeah, so I think that for the yellow, it's just kind of the commercially available yellow. We don't get too in-depth or involved in it. The publication that looked at yellow for contrast enhancement was published in OPO by Wolfson et al. If you'd like me to provide contact that publication offline, I could certainly do that. But I think that generally in clinical practice, we kind of pull off whatever yellow we have on the shelf. It doesn't seem to be, tremendously important what percentage of yellow, but we don't necessarily go into great detail in that most of the time.
Right. And when selecting the filter, it's a follow-up question. Do you usually measure their contrast with and without filter to decide, or it's more like a patient's subjective response whether they are feeling comfortable?
That's a great question as well. For filter evaluation, different clinicians have different practices. I typically just have them report their subjective preference, but I try to emulate the environment that they'll use that filter in. So if they're planning to use a filter for night driving, I might turn off all the exam lights and see if they notice it being helpful in there. Or if they want to use a filter for outdoor glare control, I'll walk them over outside and have them evaluate that filter in the real world where it's bright light outside.
Right. So I think that's a very, key important point which you just brought up. Just replicate the real scenario, what the patient is gonna use them for, and take their subjective response, because they are gonna use it for that purpose particularly, and that will help them to, go ahead with their daily activities, as your case where we wanted to kind of help the patient to perform their routine daily activities and be more independent, right?
Right.
Yeah. So I think with that, thank you so much, Dr. Gobeille, for that wonderful session, for sharing us the case, as well as I think you did bring out some very important key points on the contrast sensitivity aspect of it. So thank you so much for, doing the session for us.
Thanks so much.
Yeah. So thank you so much, everyone, for attending. We do have a session on the following Wednesday. That will be more onto the color vision aspect. So it's kind of correlating with what we are going to be discussing in this particular month. So it's going to be on color vision testing. So I hope you can join in. Until then, take care, be safe, and I will see you in the next session. Take care and bye-bye. Thank you, Dr. Gobeille. Have a good day.
Thank you. Take care.
Yeah, bye.